Welcome, everyone, and thank you for joining us for this opportunity to engage with our experts on neuroethics and innovative neurotechnologies. It is my pleasure to introduce our panel of experts who will be available to answer your questions during this live Q&A session. Our experts are Dr. Saskia Hendricks, Dr. Nader Pouratian, Dr. Ashley Feinsinger, Dr. Francis Shen, and Dr. James Nat. For more information about our experts, please refer to the speaker biographies in the center of your screen. My name is Dr. Roshan Akashamune, and I will be your moderator for today's Q&A session. LabRoots is delighted to bring you this incredible opportunity. We would also like to extend our special thanks to the BRAIN Initiative program directors, in particular Dr. James Nat, for their efforts in organizing today's session. This session is interactive, so please submit your questions by clicking on the Ask a Question box located on the far left of the screen and type your questions into the drop-down box. We'll address as many questions as time allows. Let's get started. Misconceptions about therapeutic benefit can lead to an inappropriate motivation to participate in trials and incomplete understanding of the goals and risks of a clinical trial. What is the true importance to know goals and risks?
Great. So the importance is extremely high. So in any kind of human research, whether it's a therapeutic clinical trial or any other trial where you're conducting neuroscientific studies, informed consent is a cornerstone of participation. And informed consent does clearly state that risks absolutely need to be communicated to the IRB initially and then to participants. And I think for patients to be able to make an informed decision about the risks and benefits, they need to understand what the goals of the study are. They need to understand whether there is potentially benefit to them individually, to the group that they belong to, or to society in general, and allow them to make that risk-benefit judgment.
Yeah. I would just add that in addition to it being important for informed consent, it's also important just for maximizing beneficence to participants and minimizing harm. So that is something that we care about almost independently of informed consent as well.
So the question was, what if an investigator leaves a clinical trial to go to another institution? And what about the answer to the first part of that question is often the project or the clinical trial would move with the investigator, and we would assure the resources at the new institution were adequate for supporting that project. In some cases, actually, a project might be left behind and other co-investigators would take over the management at the local site. But if the expertise or the resources were inadequate at the site being left behind, we would not continue a project under those conditions.
And what about the patients who had been already enrolled and participated? What would happen there if they were mid-trial?
The responsibility for the care of those patients remains with the primary investigator and the institution at which the original award was made. So it would not be acceptable that the responsibility over those patients were to just be dropped.
So, Dr. Shen, isn't there a real danger in regulating ourselves to the extent of entrenching in our biology, in particular, in light of the fact that it's so dynamic and there's so many degrees of freedom?
If I understand the question, and I think it's a good one, the concern is that introducing a neuroscience perspective, say in the area of criminal law, might be problematic because some combination of neuroscience, genetics, environment might lead one to think that all we are is our biology and the rest doesn't matter. I think that's a concern, but one that can be overcome with proper framing and dialogue. In fact, I think brain research here at NIH and elsewhere makes clear that the brain is intimately connected with its environment and upbringing, social engagement, brain with the rest of the body, the microbiome, everything we put in our body, you name it. So I think actually in some ways a biological perspective on the human condition and human agency opens up a number of possibilities and sort of really emphasizes the need for interventions in a lot of different ways. And so I see the concern, but I think it can be overcome. I will note that historically, maybe the questioner is thinking about this, there are historical examples where that more nuanced and integrated understanding of brain in relationship to the rest of the world hasn't been adopted, and oversimplistic models have done some real harm in policy. So it's a good thing to be thinking about, but I do think we can overcome it.
Thank you. And we have another one for you. As individuals' approaches to science and medicine vary, is it especially challenging to reach consensus on courtroom and legislative issues in regard to neurolaw? And are some individuals at a disadvantage depending upon where they reside?
To answer the first part, absolutely. Neuroscience and law, as one judge describes them, are strange bedfellows. Scientists and lawyers don't think the same way. The structures are different. I talked a little bit about this in the talk. So there's a lot of opportunity for disagreement, and it is unclear sometimes what world we want. So a hypothetical I often ask my students is, would you want a jury of 12 of the most highly trained neuroscientists? Would that excite you, or would that concern you, and why? And I think it raises deep questions, and this gets to the second part of that question about sort of depending on where you live and differences in culture and politics and representative democracy. There is often a move in science to think that once science has discovered something, it's a universal principle, and everybody should just get on board because it's been peer-reviewed in the highest journals. And yet, in many governance structures, we don't privilege, we acknowledge, but we don't necessarily privilege that scientific information, including neuroscience. And so I think it's an open question, actually, with regards to how different countries and different states and different communities and really different international organizations will choose to adopt or respond or reject some of these neuroscience findings.
Thank you. Dr. Hendricks, are there age parameters for participants in neural device research studies?
So that's a hard question to answer overall. So I'm not going to attempt to do that. I think the way we think about it is that there might be certain groups of potential participants who are more vulnerable and therefore require additional protections. And maybe in some cases, in extreme cases, we would want to exclude them from research altogether, although that also has drawbacks, as I mentioned in my talk. So I think definitely children are one of those most vulnerable groups. But I wouldn't say that there wouldn't be any case that I could think of in which it would be worthwhile to include children, because maybe the benefits of including children in principle could be enough to outweigh, for example, a minimal risk study.
And there's another question. Do you believe there should be established frameworks governing participants' access to neural devices post-trial?
Yes, I think it would be very helpful to have established frameworks for that, because guidance right now is pretty limited, especially in the realm of devices. I would say that a secondary question is how detailed should that guidance be? Because I think we want some sort of guidance that is still responsive to the fact that there's different contextual issues that matter, and that may matter a lot ethically. For example, participants' vulnerability, how much they're benefiting from a device. So we would want a framework, yes, but it would still have to allow for flexibility to respond to the contextual cases.
Dr. Shen, you look like you had a thought on that as well.
No, it's a tremendously important issue, and the regulatory law gets heavily involved, and it's very complicated. These devices could be with you for a very long time in ways that pharmacological interventions aren't.
Yes.
Can I add one element? It's especially complex because there are devices that are from established corporate entities that have a clear future. But in this space, there's also a lot of startup companies and new device designs. And it's not a simple framework to design when you're talking about a company that may not exist in the future. even though a therapy may be beneficial for a patient, a company can still go under for many reasons. So we have to think about this in many dimensions.
And there's also a question for you. Oh, please.
Yeah, I was just going to add. Oh, sorry.
Yeah, I'll go after you, please.
Yeah, I was just going to add, just from a kind of robust ethical standpoint too. I mean, these are devices that are now in someone's body, right? So if they're implanted, right? And so we do have limits on, removing them without consent. So you can have participants who may have benefited from the trial, if it's a therapeutic trial, and do not want the devices to be taken out. And that's a real problem. Can we force them to take it out, right? That's a question.
That's a very, very important question, actually, because also in cases where, as well as I do, that in Parkinson's patients, where you have these psychic side effects. And so there's, let's say, a gentleman that comes in and he has his surgery, and now he's moved into this great functional state, and the Parkinson's has been therapeutically alleviated, but he's got the gambling and the hypersexuality, and the wife comes and says, that's great that he's feeling better, take it out. And then you start to come into these ethical dilemmas. Or in the case where there's a side effect where, let's say, a patient might become aggressive. And so, of course, everybody thinks it's a good idea to turn this off or take it out, but the patient doesn't want to. And this would actually speak very much to you, Dr. Shen. How can you legally force a person to have brain surgery? And if you then decide to turn it, and this is actually a real case that happened, and then suppose you decide to turn it off, then somebody can go online or find another way to find the device that can then control the stimulation. So this is a real issue.
Yeah, I was just going to add actually on that point that there are both security and privacy concerns. So there's the security concern you just raised about who has access, and then picking up on this sort of recognition that this is a space where there are startup companies, not all of whom will make it. It's unclear what happens to that data, that brain data that then gets bought up by somebody else. I mean, it's really fascinating, interrelated set of questions.
Yeah.
And so we have another question for you, Dr. Pouratian and Dr. Feinsinger. Who should set the ethical limits to altruism, and how fixed should this be?
by our looks to each other, I think the answer is we don't know. And that's part of the work that needs to be done. There has been work done in other fields that are not neuroscience. And the example we often think about are living organ donors, which is a very altruistic thing to do. You're basically giving of yourself. And that is an invasive surgery. There's potentially life-threatening surgery, although still a safe surgery, otherwise we wouldn't do it. And so I think the jury is still out. I think it depends on the potential benefits that we as a society judge may come from allowing people to exercise their right to altruism. But I'll let Ashley talk a little further about that.
Yeah, I mean, I think that's right. I mean, I think, philosophers, we might have a bit of a biased opinion that we should be heavily involved in the discussion. But in the space of, ethical limits to altruism in a particular type of research, I mean, it would be reasonable to expect that limit could shift around depending on the risks and the benefits of that research. And it would also be reasonable to expect that the limit would be context dependent, not just on the research, but on the participant, right? So this is a fairly complex set of issues. I don't know that we have to settle on where the limit is at this point, but I do think that we need to be very mindful of this idea that there is reasonably a limit, and we haven't really paid enough attention to the fact that there could be very ethically concerning altruistic sacrifices, and that is maybe where we should start the conversation. So I don't have a straight answer as to what the limit should be, but I do think it should be in an interdisciplinary discussion, and we should learn from clinicians, patients themselves as well. I think we can learn a lot from their narratives on what it's like to give back in some of this research, and ethicists as well.
But I will say right now, the limits of altruism are determined by each institution's individual IRB, who determines whether or not something is okay to be done or a study can be conducted. And that's where there's a lot of variability, as those of us who have started to look at these issues have noticed that you can have the same exact study reviewed by two IRBs and get completely different responses. Some IRBs will say, we will let anything go as long as there is informed consent. You inform someone of all the risks, and if they still want to do it, then that's their choice. And that might be too extreme a view. And there's other places that say it doesn't matter, altruism, if there's no potential for direct benefit, then the study should never be conducted. And that's probably an extreme view. So there's somewhere in the middle, and it's going to be variable depending on the study.
There's actually a question here about the IRB. What happens when an IRB doesn't understand the reasonable risk-benefit ratio or just the risk that a patient is willing to accept? And can an ethicist be pulled into the equation to reason or influence the board member? And is that ethical?
So I think yes, and that in fact, I'll give a case example, then I'll let Ashley speak. That's exactly what happened in our situation where one of the institutions that's part of a multi-institutional study pulled in their ethicist because they had issues with a non-therapeutic trial, concerns about therapeutic misconception. And they did two things. One is they consulted with an ethicist at their institution in terms of the validity or the allowability of the study. But they also introduced something which I'm not sure is the right answer either, but they've introduced an ethicist into the consent process to actively screen patients to verify that they are enrolling for the right reasons and they understand the purpose of the study. But then the big question becomes, what are the tools that the ethicist has to evaluate those, or anyone has to evaluate those? And there is a space that a lot of work still needs to be done.
Yeah, and I agree with that answer completely. This is a fairly common question that comes up. So I've seen many of my colleagues be pulled in to talk with IRB boards about, the amount of money, right, that they're going to give to compensate, and there have been concerns about that. So this is a common thing, and I think it's a good thing. And then I sound like a broken record, but I would just say that probably the best solution is to bring in an ethicist that can work interdisciplinarily with the clinician as well to do this problem.
And then what happens when a patient, sorry, did you have something to say?
Well, I was just going to say, going forward, actually, for the BRAIN Initiative awards in this space, new awards, we actually are asking the projects to come in with a common IRB, even when the surgical sites and the where the patients are being recruited might be at different sites. So in that case, then we will have a single IRB that would apply to everything that went out on that was funded by that award. That won't necessarily get rid of all of the problems or issues, and certainly an IRB could also change its decision, mid award or mid trial. But it would help to get rid of the issue, or to at least address the issue of competing standards and competing demands from different institutions for an award that is made at multiple institutions.
And then what would happen if a patient originally agreed to take on the risk and then later suffered some of that risk and wanted to move into the legal space? How would you handle that, Dr. Shen? What do you think about that?
I think it goes back to what we just heard, and it has a lot to do with consent and the magical, mystical challenge of trying to properly understand and articulate the risk and the benefits. And that's really difficult to do when you're dealing with the organ of the brain in new experimental studies. I mean, it's hard enough to do in areas that we already know. But I say it also sound like a broken record, but it really depends. And probably it would be, I think, you'd look a lot at the procedural steps that were taken or not taken, and to see if they did due diligence.
In the case of clinical trials, without the potential for therapeutic benefits, such as those projects participating in the Brain Research in Human Consortium, the concept of altruism as a motivating factor becomes exponentially more important, as there is clearly no intended direct therapeutic benefit to the individual or society. So, is the altruism a form of concentrated egoism above the real role that motivates patients?
So, I think if I might be misunderstanding this question, so Dr. Pouratian can chime in, but if the question is asking something like, is, altruism really always a form of self-interest or a form of gaining something back for the ego yourself? If that's what it's asking, that may not necessarily be the case. That's a good question. It's a fairly robust philosophical question, right? So we have these arguments in philosophy about whether altruism is truly possible, right? This idea that you're really always doing something only to benefit others, right? And so we were just chatting before, Dr. Pouratian saying, look, even when people do things altruistically, they often feel good about it. Right. So is that really the thing that's motivating them? And I would say that that's possible, but it's also possible that although some people feel good as the result of doing something altruistically, that doesn't necessarily mean that they're doing it so that they feel good. Right. So it might not actually rise to the level of being the motivator. And so it is possible to have true altruism where you're really motivated to help other people, but subsequently get a benefit. So I would ask the person asking this question to try to think through those distinctions to see if we can really find a space for altruism.
And actually, sorry, did you have something to say?
No, I agree.
The question is, or the statement, I really like that contributing altruistically actually can increase your quality of life. This can feed back to improve medical response or state of health. Have there been any studies on this?
Not in this space, not in the neuroscientific space, and I have to admit I don't know enough. Again, I'm going to call in the transplant space, but I imagine there's been pretty significant work in living donors in terms of what they experience and why they do it and their motivation to do so. But I will say from personal experience, having worked in a couple different trials, especially in the neuroscientific space, there's a unique component to the altruism, which is that most of the people that are participating in these studies have some kind of chronic neurological disease, some kind of disability associated with it. And as a result, they've lost some quality of life. They've lost some kind of interaction with society in the way that they knew before their disease. And participation, especially in more chronic studies, offers them a purpose. It offers them a way to integrate back into society, which I think ends up being a very significant benefit, or I should say, because we haven't proven it, is potentially a very significant benefit in terms of their psychological state and their overall mental health. So I think if we dig into it, there is significant potential for improvements in quality in life and sense of self and well-being. I'll let Ashley comment on that.
Yeah, I mean, this is an interesting question, and it's very possible that that's the case. It's also possible that we could find other kind of correlations between, someone's ability to satisfy or pursue the things that they care about and their blood pressure, right? So having less stress, having lower blood pressure, having better cardiac health, like who knows what the correlations might be between altruism and some of these things. And that's, I don't know of any studies that have done that specifically with altruism. It would be interesting. And I would just add that even in the absence of those correlations, we still might have a very good reason to consider improvements in quality of life as being something we care about promoting in the research space.
So we have time for just one more question. And I guess I would like to pose this to all the panelists as it's an open question to any of the panelists. For any of the panelists who work in a state that allows physician-assisted death, how do you believe neuroethics can help guide lawmakers to expand the criteria of PAD to include those with treatment-resistant psychiatric diseases, if at all? So we'll start with Dr. Shen.
I'll use as an example dementia, let's say Alzheimer's, there has been a move and a discussion emerging about expanding opportunities for physician-assisted suicide to populations that don't fit the traditional criteria. So those criteria in the states, the 5 states where it's available in the United States, you have to have a terminal illness, see about 6 months or less to live. There are these other safeguards like mandatory waiting periods, and crucially, you have to be mentally competent to be able to have the law recognize your decision. So as we move more downstream, that is more than 6 months away from that terminal ending point, it raises a really challenging set of ethical questions they're very ripe right now. And I'll just, without taking a view on which is right, I'll just lay out one of the big debates, which is how much autonomy does someone have with a neurodegenerative disease? Their brain is changing in ways that we think may affect their competence and their capacity to make this really important decision. At the same time, what's happening is that they're experiencing, and I think this gets to the question, the pain and the challenge of that disorder and that degeneration in new ways, and in ways that might make them and their family think that physician-assisted suicide is an appropriate, indeed a humane and ethical response. So I just think it's a really great question. It's really challenging. And I hope that we'd have an informed discussion around it in the years to come, because it is coming. It's already happening. The discussion.
So Dr. Nat and Dr. Saskia, would you like to comment on that?
Well, it's more of an ethics issue, if you'd like to try.
Well, it was asking about, do you believe neuroethics can help guide lawmakers to expand the criteria?
Yeah. So I think I'm going to interpret that question a little bit more broadly, and I do think that conceptual and empirical work in the space of ethics can help elucidate what the main questions are and how different stakeholders think about them. And that can in turn help policymakers answer complicated questions like these.
And Dr. Pouratian and Dr. Feinsinger?
Yeah, I mean,
good question.
I think, yeah, good question. I think that it's possible that some of the stuff we are learning about the brain through advances in neuroscience could help us kind of understand different levels of cognitive capacity. So if we had patients where we were not sure how much capacity they had with respect to being able to consent or make decisions about end of life or physician-assisted suicide, I imagine that there may be a space to come in and maybe use some of those techniques to help confirm that indeed the patient does have enough capacity to do this. But I would be very careful about that. And I would say there's a lot of philosophical and ethical work that needs to be done before trying to use any of that technology in this space.
I think the really a very interesting part of that question is that it asks about expanding the criteria for physician-assisted death to include those with treatment-resistant psychiatric diseases. What do you think of this?
So, I will add one aspect, which is perhaps overly optimistic, but we need some optimism here, is that we are living in an era that we are starting to understand psychiatric disease in a completely different light, where we understand it, and I often say, just like any other neurological disease that can affect the brain and result in neurological impairment. In neurology, we think about people that have symptoms that we can actually physically assess and do a physical exam on. In my opinion, and I think in many people's view, psychiatric disease is not that different, except that the dimension space is in the cognitive and interactive and the psychiatric space, those types of assessments. So I think we need to be careful about losing hope, especially in an era where we are investing tremendously in developing therapies for these very people who have treatment-resistant psychiatric diseases. So I think that needs to factor into the equation as well.
If I could just add one last wrinkle on that, we have to be really, we have to have a very challenging discussion about limiting conditions. So take Down syndrome. Iceland is almost eliminating the reproduction of Down syndrome by parental screening and selective abortion. For some, this is a miracle and awesome. For others, this is horrible. But the question leads to those sorts of potential policy implications, because if you can figure out at 35 that you have this neuropsychiatric disorder, you might be able to figure out even earlier. And at what point do you evaluate risk and benefits? Who gets to make those decisions? Just this really challenging ethical terrain. And I agree with everyone here that there's really opportunity for philosophy, for ethics, for empirical work, conceptual work. And again, I hope we do it.
Well, thank you everybody for your time and for these wonderful answers. And thank you to our audience for those thought-provoking questions. I would like to ask you to continue submitting your questions to our speakers, as they can follow up via email. So thank you again to our speakers. And coming up next, our Innovative Neurotechnologies track is about to begin, where our speakers will explore the most cutting-edge innovations that will foster the advanced understanding of the human brain by supporting the development and application of such technologies. Hope to see you there.